All right, today we're going to talk about the Difficult Airway Society guidelines and overview. The Difficult Airway Society guidelines are extremely important because they're all related to us being able to administer safe anesthesia, in particular in managing patients' airways. So, as an anesthetist, we must be the airway experts, and often we will be called upon to manage or assist our other colleagues in managing challenging airways in the emergency department, in the ICUs, also in the wards, and during a resuscitation. They expect us to be the airway experts. And for us to become the airway experts, we have to know how to manage difficult airways and the nuances around managing those airways. So it's important that we look at the 2000, in fact, it's the 2025 guidelines, which build upon the 2005 guidelines on the Difficult Airways Society guidelines. There are also other guidelines that they started including after 2005. Um, for example, the awake tracheal intubation guidelines, the guidelines for removing a hematoma in the neck after neck surgery, like thyroid surgery. So there are a whole lot of guidelines that started coming in, but the main guidelines started in 2005. And how these guidelines came about is because there were airway incidents in the UK that led to the death of patients. So they had to sit down and try and formulate a set of guidelines that would improve safety around airway management. And I must say, these guidelines have helped so many people, not just in the UK, but even globally. And the institution of these guidelines also has helped many anesthetists in the African setting. We do not have any South African difficult airway guidelines. We have adopted the Difficult Airway Society guidelines into our own practice because we find that they are relevant to our setting. And yeah, there's nothing else that we could actually add to the guidelines. They are very, very, very good. Having been exposed to North America, there are no clear, difficult airway guidelines I have come across. I serve to be corrected in North America. They do have guidelines in managing patients' airways, but what I find that their guidelines are not as clear and crisp and easy to follow like the UK guidelines. The emphasis on the 2025 guidelines is on first pass success. So, in my training in anesthesia, uh, our focus was just, get that tube in. And the focus was mainly with direct laryngoscopy. And then when you do encounter challenges, you would do your best to manage that patient's airway. And if you could not intubate the patient, you would always fall back on mask ventilating the patient and calling for help. We always had some form of help around. If you couldn't, then you have to wake up the patient if you can and call your consultant to come and help you. So that was our general approach in my time of training. And I must say, the teaching was never around first pass success. It was just about manage the patient the best that you can um, safely. If you have multiple attempts, so be it, but make sure you get it. But the teaching now is such that we want to have first pass success because number one, first pass success means that your patient is safer and it also avoids issues around airway morbidity, like, for example, causing trauma to the airway, like soft tissue injuries, dental injuries, uh, and also it avoids hemodynamic instability during the time of airway manipulation and definitely mitigates issues like aspiration. So first pass success is where you want to be, and that's the emphasis of the Difficult Airway Society in 2025. So these are things that I have learned in my training and things that I have come up with in managing many airways that I've experienced in the last couple of years. I wish I actually knew this when I was a trainee because it would have helped me avoid many struggles. So there are 7 things whenever you're managing an airway. So like for when I'm teaching trainees now, like residents or registrars or respiratory therapists or anyone who's managing the airway, this has now become my mantra. This is what I teach them, and I can guarantee you that if you follow this template, um, you will be okay. You'll definitely avoid many airway catastrophes. So you have to be methodical and you have to have a system. So these are the 7 things that I could swear by that would help you in managing a patient's airway. If you don't do these 7 things, yes, you might get away with it sometimes, but when you are faced with a difficult patient or a tricky airway and you don't do these things, you might end up in trouble. So, number one, this is a very important slide, not just for the exam, but for your training and for whatever you're going to do in your future career. Number one is examine the patient. Don't ever anesthetize a patient you've never examined. At least have an opportunity to talk to the patient, examine them. It will save you. If you don't examine the patient, you are definitely going to miss things and you're going to run into trouble. So, examining the patient is extremely important. Speaking to the patient, obtaining a history from the patient relative to the relevant to the anesthetic. You don't have to dig too deep into many other issues that might not be relevant to the airway management at that particular time. But examining the patient is important. In an emergency, it may not be you may not be able to get a full history. For example, if a patient is brought to the hospital, they have collapsed, you can't ask them, "Are you diabetic? How many operations have you had in the past? Do you have any anesthetic history?" No one will know. The patient just collapsed. The relatives are not around. The patient is just here with you, and you need to manage them. They need to be rushed into surgery. So if you examine the patient, even if you do not have a full history in that instance, it will help you a lot. The next thing is pre-oxygenation, and the Difficult Airway Society um, really emphasizes this now in the guidelines for 2025, the importance of pre-oxygenating the patient adequately. And they also advocate now for continuous oxygenation during airway manipulation. So not just giving the patient oxygen before you induce, but continuously giving them oxygen, especially in patients who are high risk, who may be physiologically difficult airways. Positioning, extremely important. This is one thing we never paid, or I would say I never really paid much attention to during my training. My focus was just getting the patient onto the bed, putting a pillow under their head, and giving them medication, putting them to sleep, and then once I'm sure the patient is well relaxed, immediately beginning to perform laryngoscopy. But positioning is important. And I began to realize that because I did not position patients properly, some intubations became unnecessarily difficult. They were not supposed to be, but inadequate positioning or not positioning patient properly can make an easy intubation difficult. And also understanding what you should do in certain positions. Like if, for example, if a patient is in the right lateral position, you can intubate in that position, but you need to be aware of that and what are you going to do? What are the airway maneuvers that you're going to perform in order to intubate that patient? So positioning is extremely important, not just for laryngoscopy, but also for uh, ventilation. So there are some positions that make ventilation difficult. There are some positions that make ventilation easy. So you need to be aware of that. Drugs are also important. And the Difficult Airway Society talks about adequate dosing, and the right choice of drugs. Equipment, extremely important, especially in our setup. If you're working in a hospital that is poorly resourced, you might find that some things are not there. And it's important for you to make a decision of how you're going to manage that patient's airway if certain pieces of equipment are not there. So it's important that you are aware of what exactly do you need. You should not be putting a patient to sleep before checking your equipment because you might end up in trouble. For example, typical situation is putting a patient to sleep and you have not checked your suction. Then the patient starts regurgitating gastric contents. Then you might run into trouble because you don't have any suction, or you didn't check your suction, and then you go through the entire operation. Now you want to extubate the patient, and then you realize my suction is not working. Then you're going to have a problem there. So always make sure your equipment is checked. Plan. A plan is extremely important. So don't just give an anesthetic and just say, "Oh no, I'm just going to intubate everything's fine." You're not thinking about other things that might possibly happen, and if you've not thought about them, you're not going to be prepared for them. So when you've thought about something, you can easily be able to deal with that situation. If you know, like, if I struggle with this, I'm going to do this. I'm going to fall onto this. I'm going to pivot. If you've not thought about that, when things go south, you're not going to be able to get on top of that situation. Another important thing is the team. So you need to have people who are working with you. The nice thing in South Africa is that your nurse, you have an anesthetic nurse who's dedicated to help you. So you need to have good communication with that nurse, and you need to be on the same board. There's something that they talk of that's called a shared mental model. So if we are having a potentially difficult airway, I might need an extra hand on top of the anesthetic nurse. And I communicate to the team, including the surgical team, before we start, especially with ENT or cardiothoracic cases. You are going to speak to your team that we have a patient here who is a potentially difficult airway. What am I going to do? I am going to uh, put the patient to sleep, or I'm going to sedate the patient. I'm going to attempt to intubate the patient. If I fail, I'm going to ask my other colleague to try as well. If he does not succeed, we're going to mass ventilate the patient. If we can't do that, then if we're struggling with that, then we're going to go for front of neck access, or we have the ENT standby to perform a rigid laryngoscopy, and then we are going to do a tracheostomy if that fails. And throughout the process, we're going to be oxygenating the patient. So that's a shared mental model. And then you need to speak to your team and say to the nurse, okay, if I am struggling with this, bring this. Or if we are not winning, please call the consultant. Or, so there has to be some sort of plan, and everybody needs to be on board and know exactly what's happening. So when things are going south, the nurse will be like, "Oh, doc, okay, you said that if you try twice and you can't, you're struggling, you're gonna call the consultant. Can I call the consultant now?" Because she knows what you were doing, and she knows what is going wrong, and she's also aware of what's happening with the patient. Having a shared mental model can save the patient's life, and it can save you from having a catastrophe. And that's one thing the Difficult Airway Society also advocates for: having a plan, having a team, and being able to communicate with your team what is happening, and not to have what we call a fixation era, where you're just focused on doing one thing and you keep getting it wrong, and you keep telling yourself, "I'm going to get it right, I'm going to get it right." And that's when things go wrong. Then the last thing is knowing the algorithms. So you need to know that if this is not working, I'm going to do this. If this is not working, I'm going to do this. So these 7 things are going to help you to have first pass success. I spent a lot of time on that side because it was important. Airway examination, I've already talked about that. The important thing, as I said, is obtaining the history. So in some countries where there are electronic patient records, it makes it much easier to read up on the patient's history or get to know about the patient's history because you can look at previous anesthetic charts, especially if these records are shared amongst different hospitals within a given province or within the entire country. Then you can always go back and look at the previous anesthetic notes, and you can be able to see what the previous anesthetist did, what challenges they experienced, what tube size they used. It can actually help you to plan your own anesthetic based upon that previous information. If the previous anesthetist writes that this area was difficult, we had to do this and that, it's a warning sign to you that be careful with this patient's airway. Consider, A, B, C, D. I'll give you an example of a patient who was in Pretoria who had a prostatectomy, and I mean, he doesn't have a difficult airway, but because he has all these blood vessels, engorged blood vessels in his tongue, when the anesthetist performed laryngoscopy, unfortunately, he bled so much from just the laryngoscopy. The surgery was uneventful, but the laryngoscopy led to a lot of bleeding because of the abundance of vessels in his oral cavity. He actually needed to be intubated for a week, and the ENT team was actually called to cauterize some of those bleeding vessels in his airway. So when he came in for surgery last year, he was coming in for anterior, I think it's an APR. So basically, it's colon surgery, all right, because he had this cancer and he was having a major resection of his colon. He told, it was on record actually, that he experienced that. So he was very worried coming in for surgery. So my decision was I'm going to perform fiber optic intubation. So fiber optic intubation would avoid traumatizing the patient's airway and avoid traumatizing the tongue. Because last time that's what happened. He bled so much and they struggled to control the bleeding. So fiber optic intubation went on quite smoothly, and we packed his oral cavity and made sure that he didn't have any bleeding. So post-op, we managed to extubate the patient. It was, I mean, intubation and airway manipulation was uneventful. He did very well. And he was very happy because to be intubated in the ICU just because you were bleeding in the oral cavity following an intubation is not great, So um, you don't want an anesthetic to be a cause of morbidity. So history is extremely important. So asking the history, if possible, if you can get it, is very, very, very important. It can save you a lot. And if you just look at your patients, you don't ask them the history, they can't tell you what you've not asked for. So you've got to ask. Relevant investigations as well, something that is relevant to your airway management, airway aesthetic, that's what you want to institute. This must be performed before induction. So the Difficult Airway Society says it's important that you do it. Don't allow the surgeons to rush you because it becomes a safety issue. Even if a patient is deteriorating, if you rush and you try and manage the patient's airway and the airway can potentially be difficult, you're going to have a worse off outcome. So you should train yourself to be able to examine the patient quite quickly and make a decision. That's something you have to train yourself with normal patients so that when you have an emergency, you can quickly make a decision. I couldn't do that, but it comes with training. Unless you train yourself and you prime yourself to do that, you won't be able to it won't be like a reflex action. So just by looking at a patient, I am able to decide the tube size, the oropharyngeal airway size, the blade I'm going to use, and the potential positioning that I'm going to put the patient in. And also, I can already make a decision, even without knowing the patient's actual weight. I can make a decision of how much drugs the patient was going to need in terms of muscle relaxation, in terms of induction dose, and how much I need to back the patient, or should I not back the patient. All of those things in my head, I've already decided. I would have been able to make a decision. And also, I can decide on the size of the laryngeal mask airway just by looking at the patient. So you need to get to that level. Um, then the other thing they also outline in these guidelines is what we talk of an anatomical versus a physiologically difficult airway. So an airway can be difficult, but it can be anatomically difficult or physiologically difficult or both. So if an airway is anatomically and physiologically difficult, the chances of having an airway catastrophe is much higher. So you have to be very, very careful. And we're going to talk about this. And as I said, in the guidelines, they have made a huge emphasis on this. Then this is also my own thing. I learned it from one of my consultants during my training. So I feel this is an important thing to know about because again, I send I send trainees to, can you go and examine the patient's airway and report back to me? And often what they'll just tell me, oh, the patient is a Malampati 2. So I'm like, okay, patient is a Malampati 2, so what? Because based on evidence, Malampati does not guarantee that it's going to be an easy intubation. There are so many other things that are involved in airway management, not just the Malampati. And when you have examined the patient's airway, you must be able to answer 4 questions. So that's what I always teach my trainees. When you're going to examine the airway of a patient, do it in such a way you can answer these 4 questions. If you cannot answer these 4 questions, you have not examined the airway properly. So the first thing you have to answer is, can I mask ventilate this patient with ease? And if I can't, how can I make it easier for myself? And if it's still not possible, what must I do? Because there are patients that you may not be able to mask ventilate. Then those patients, you need to think of yourself, how am I going to oxygenate this patient if I'm struggling to mask ventilate? We'll talk about those options. The other question you should ask yourself, can I perform laryngoscopy? So what I'm saying, can you perform laryngoscopy? We're talking about the ability to insert the laryngoscope into the patient's mouth so that you can be able to see the glottic opening. So that's an important thing. And the next question is, can I intubate? So the ability to perform laryngoscopy does not necessarily mean you'll be able to intubate. So you may be able to see the glottic opening, but it may be difficult to insert the tube. That can happen as well, and it can be very, very frustrating. So you need to be aware of that. Then ease of front of neck airway. So this is when you're going to do a cricothyroidotomy. You really don't want to be there, but it's an important thing that you need to think about. Especially if your hospital, you've got ENT services. This is something that you need to be aware of. So if you feel that you're struggling, then you're gonna call the ENT guys to come and rush and help you. But there are situations where front of neck airway or front of neck access is impossible, and I will show you those. So in that instance, even if you call in someone to come and do a emergency tracheostomy or cricothyroidotomy, it might not be possible. So you need to think about those things. So you need to be able to answer those 4 questions after you've examined the airway. If you can't, then you have not examined that airway properly. So when it comes to airway examination, again, as I said, people will just say, oh, patient is Malampati 1, Malampati 2. That's not enough. You need to come up with a risk stratification system as well. So this is called the Simplified Airway Risk Index. So the Simplified Airway Risk Index looks at different things. There's a paper on this. You won't need to read the paper. So I have just simplified everything for you. So this is like basic the summary from that journal article. Again, I encourage my trainees to be able to answer those four questions. And then after they've answered those four questions, I want them to tell me what is the simplified airway risk index. So, what does it look at? It looks at the mouth opening, thyromental distance, the Mallampati, the neck movement, ability to pronath, the weight of the patient, and history of difficult intubation. So if the patient has a score of greater than or equal to 4, that indicates it's going to be difficult. So if we have a patient who's greater than or equal to 4, we need to have a plan. We need to decide what are we going to do. Maybe I need an extra hand. So in my case, I would call a respiratory therapist, or if you've got one in your hospital, or an AA. So you might not have that. Maybe you need to call another anesthetist or a senior person, because our nurses in the South African setting are not anesthesia trained. They might know some things in anesthesia. They are the anesthetic nurse, but they may not be able to rescue you when you've got an airway issue. They can assist you, but they cannot rescue you. So you need to decide who do I need to come and help me if I'm struggling with this, if I think this patient is going to be potentially difficult. But if you go in blindly, you're going to have a problem. Then the Difficult Airway Society also noted in their guidelines that the upper lip bite test is quite a sensitive marker of a potentially difficult airway. So it is part of the SARI. So this is it's related to the ability to pronath. So you cannot bite your upper lip if you cannot pronath. That's for sure. You have to be able to have some sort of movement of the lower jaw for you to be able to do that. Then what they also added was patients with obstructive sleep apnea can potentially be difficult airways, so you need to be aware of that. However, obesity is, on a patient who's obese is not necessarily a difficult airway, and I have seen that. So patients who are obese does not automatically mean they are difficult airways. They can potentially be difficult. Why is that? They can be physiologically difficult. So patients who are obese may have a higher oxygen consumption. And it also might be difficult to pre-oxygenate them properly, because some of them when they have excess fat tissue, it can decrease the FRC, because their diaphragm is pushed up and it reduces the FRC. They can have a lower FRC and tend to have faster desaturation. So I've seen that quite a number of times with obese patients. Sometimes what happens is you try and pre-oxygenate them, and then you intubate them. SATs are okay, but once the tube goes in, the SATs can actually drop to like 88, and you're like, but what did I do wrong? I mean, I managed to pre-oxygenate well. The tube is in. I'm actually mass ventilating. I'm getting a capnograph. Everything's fine, but the SATs initially actually drop, and then afterwards they pick up. So that might be a problem with those patients. And also they have a higher risk of having atelectasis. That's why when you pre-oxygenate them, you want to use higher flows and a little bit of PEEP. So that's the issue with the obese patients. And what I'd also like to outline is that the ones that can potentially become tricky amongst the obese patients are the male obese patients. So with female patients, if they're obese, the fat distribution is mainly in the buttock and abdominal area, whereas with males, the fat distribution tends to be around the neck, and that's the problem with males. And if you look at the stop bang score for assessing for the risk of obstructive sleep apnea, you see one of the parameters are neck circumference, and other parameter that they also talk about is males. So they look at the gender and they say, maybe you should say sex. They look at the sex and they say males. So males with the increased neck circumference are at a higher risk of having OSA. So, and that's got to do with the fat distribution. So with obese males, very, very tricky. They can be tricky. Those are the ones that are more likely to snore. And once you give them an anesthetic, most of the time they obstruct. And when they obstruct because of the excess tissue in the airway, it becomes very difficult to mask ventilate them. Even when you put an oropharyngeal mask airway, it can be difficult. That's why the guidelines say that patients with OSA can potentially be difficult. So you need to think what you can do to mitigate complications in those patients. Anatomical difficulty, this is an example. So this is a pediatric patient with a swollen tongue. It's going to be extremely difficult for you to intubate this patient using conventional means. So you see this child actually required a nasal intubation. The nasal intubation also is not so easy. It does take a certain level of experience. So this is an example of an anatomically difficult airway. Then physiologically difficult airways, these are patients that easily desaturate. A typical example is a neonate. So you know that neonates have a higher oxygen consumption, a low FRC, they have got inefficient ventilation, so they easily desaturate. So these patients are physiologically difficult airway. Another example is a pregnant patient. So pregnant patient, remember, it's the mother and the baby. They have an increased oxygen consumption. They have a low FRC because of the gravid uterus pushing up on the diaphragm, reducing the residual volume. So then these patients tend to desaturate very, very quickly. The other thing with these patients is because they also have a higher risk for aspiration. So you cannot just bag them to, like just routinely bag them because you just increase the risk of aspiration in these patients. It's actually worse when the patients have got hypertensive disorder. They desaturate even much faster. And there's a study which was performed in Cape Town to look at this. And what they found is that the patients who were preeclamptic desaturated much faster following preoxygenation when they were having a general anesthetic, as opposed to the non preeclamptic pregnant patient. So, in order to reduce the chances of the patients desaturating, we have to preoxygenate them. So, preoxygenation is a wonderful technique in that it allows us to create a store of oxygen whilst the patient is in that apneic state. So, we prolong the apneic state in a safe manner so that we can be able to manipulate the airway. And I mean, it's kind of intuitive. It's difficult to manipulate the airway in a patient who's actually breathing. So, in order for us to optimize our ability to manage the patient's airway and to manipulate the airway, we need to create conditions that facilitate that. And one of the things is making the patient apneic using pharmacological means. But the downside is that now the patient is going to desaturate. But in order to prevent that from happening, what are we going to do? We're going to pre-oxygenate them. So how are we going to pre-oxygenate them? We can use a mask to pre-oxygenate them. We can also use Thrive. So on the right side is Thrive. This is transhumidified rapid insufflation ventilation exchange. So Thrive is not high flow nasal prongs, and it's similar, but it's not. Okay. So during COVID, I know people were using high flow oxygen. Thrive also is high flow oxygen, but it's different in that there is ventilatory exchange. So it oxygenates the patient, but it also blows up CO2. The air is humidified, and it allows you to pre oxygenate the patient without actually placing the mask on the patient. It also will allow you to manipulate the patient's airway while oxygen is going through to the patient. So it will avoid desaturation in the physiologically difficult patient. So it's superior in terms of oxygenating the patient. And also, patients who are claustrophobic, this is probably the way to go. Um, they will be more comfortable having uh, these prongs in their nose as opposed to having a mask over their face. The downside, though, is that Thrive and the consumables are quite expensive. So you cannot do it for each and every patient. Then coming to, yeah, still with pre-oxygenation, our target is an ETO2 of greater than or equal to 90%. So your machine is going to show you the end tidal oxygen. So next time when you're giving an anesthetic, look at the end tidal oxygen. If you're going to pre-oxygenate properly, you have to reach almost 90%. What I have found though in practice, once you go above 85, you would have pre-oxygenated reasonably enough. The difficult airway guidelines, they'll talk about getting up to 90. And when you are pre-oxygenating them, you must make sure you have a very good seal of the mask. So in this case, that's why the mask is completely tight around the patient's nose and mouth. It's a bit uncomfortable for the patient when the patient is still awake, but you have to tell them that for this, it's important that you hold the mask tightly. Otherwise, you will not be able to reach an end tidal of 90 because you will continue getting mixture of the 100% oxygen with the atmospheric gases. So then you will not be able to reach that 90. And if you don't reach that 90 or above 85, entitled oxygen, you would not have pre-oxygenated enough, and your patient has a high risk of desaturating while you are performing laryngoscopy, and that's not what you want. The airway guidelines, difficult airway society guidelines as well, are emphasizing capnography tracing during pre-oxygenation. So they are saying that it's important that you see a capnography tracing when you are pre-oxygenating. So some people pre-oxygenate and they don't pay attention to the capnography tracing. That is a safety issue. So the guidelines clearly state not only should you look at the end tidal oxygen, but also you must see the capnography tracing. You must see those waveforms as the patient is taking breaths in and out. The reason is because number one, it shows you that the patient is taking adequate breaths. Number two, when you finally get to the point of intubating the patient, you have actually verified that your capnography is working. So when you connect the patient up to the ventilator, you know that before you started the anesthetic, your capnography or your capnography monitor was working. So if you're not getting capnography, one of the reasons might be you you might have an esophageal intubation, or the tube is not placed properly, or patient might have decompensated. So a fall in the ETCO2 can occur because a patient has gone into cardiac arrest. So if you had a capnograph before and then you induce the patient, you connect the patient to the intubator, and there's no capnograph, that might signify the fact that the patient is in has hemodynamic compromise. Because if you're not getting a CO2, maybe the patient has had a pulmonary embolus or the patient has a cardiac arrest, and the ability to identify that can actually make a difference in your ability to save the patient's life. That's why it's important to have a capnograph tracing when you're pre-oxygenating. They also emphasize having an audible SpO2 tones. As you are pre-oxygenating, you need to hear that SATS monitor, and you need to be aware of those tones as you are intubating the patient and everything that's going on. So it's part of the situational awareness. So your SATS monitor should be clearly audible. You must hear it. You should not mute it when you're performing laryngoscopy, um, because that's a safety issue. Then the actual handling of the mask. So they also talk about this. So in the university, you might have been taught the EC technique, where this is how you'd hold a mask, shown here in B and B. The new guidelines show that this is actually an ineffective way of holding the mask. And we've demonstrated this actually in the operating room with one of the trainees. I demonstrated to them that holding the mask in the VE, using the VE technique, was more effective than the CE technique. It was easier to mask ventilate the patient using the VE technique, especially when you've got these obese patients, or especially you've got those patients that you are struggling to get a good seal on the mask. When you use the VE technique, you're going to get a better seal of the mask, and also you're going to have better chest excursions. So that this is also something that they outlined in the guidelines. Techniques for pre-oxygenation. So one of them is what we were talking about, having the patient just take breaths in and out until they reach an ETO2 of 90. They also talk about taking one vital capacity breath, or what I have seen in practice is encouraging the patient to take 4 deep breaths. That helps you to pre-oxygenate the patient quickly. Here on this picture, you can see that there are 6 techniques. So I'm not aware with the extended deep breathing. I have not done it before, but I mean, it's something that the authors talk about. Extended deep breathing, 8 deep breaths, single tidal capacity breath, one vital capacity breath. The tricky part with the vital capacity breaths is I don't know what the patient's vital capacity breath is, because I mean, we don't normally measure those things when the patients come in. So what I'll be more comfortable with is patients just taking tidal volume breathing until an ETO of more than 90, or 4 deep breaths. I ask them to take 4 big breaths. Then I know I've pre-oxygenated the patient sufficiently. So some texts will talk about giving oxygen for 3 minutes as a way of pre-oxygenation. The tricky part with that is you can get the patient to breathe in oxygen for 3 minutes, but that does not guarantee that you're going to reach an ETO2 of 90. So your target in giving the oxygen to the patient should be to get to an ETO2 of 90. It's not necessarily the duration of time, but it's getting that ETO2 of 90. As long as you get to that ETO2 of 90, you will be able to prolong the apneic time safely. Positioning. So positioning is also very important. I mean, I've been talking a lot about that. So you can either use pillows, you can use blankets to position the patient. And then if your hospital has got what we call a troop pillow, as you can see on the left, this is called a troop pillow. Typically, we use it in obese patient. This patient is not an obese patient. It just helps you to maintain the tragus and the sternum at a set, at the same level. And it has been noted that when the tragus and the sternum are at the same level, you will be able to see the vocal cords with ease when you perform laryngoscopy. This is just showing you the positioning in a child, how you would position a child. Then this is the obese patient. Picture shows you the difference that you will have between not ramping and ramping the patient. When you ramp the patient, the ear and the sternal notch are at the same level, the head is elevated, and it's easier to perform laryngoscopy in this position. This is also another position that you can put the patient in. This is an ideal position for obese patients. Slight head up, you could have a head up position, or what would say a reverse Trendelenburg position. This position is good if not just for pre-oxygenation, but also if you want to intend on bagging the patient. Let's say it's not an emergency, it's a elective sequence induction. It's easier to bag an obese patient in this position. Why? It's because if the abdominal contents will not be pushing up on the diaphragm as much, so you free that diaphragm. And also in this position, you prevent the patient from getting atelectasis. And if you're worried about aspiration, and it does reduce the risk of aspiration because now the patient is in a head up position. So gravity will assist you to avoid gastric contents from moving upwards into the oral cavity and into the airway. I've also found that it's if you're going to mask ventilate the patient, somehow it's easier. It's much easier to mask ventilate them when they are in head up position. You will get better chest excursions when they are in this position as opposed to ventilating the obese patient when they are flat. So when they are flat, you just sometimes all you see is just movement in the neck region and very little movement in the chest. But when you get them head up and or even reversed Trendelenburg position, and you start bagging them, you will get way better chest excursion, and you actually get good much better tidal volumes, and then you'll be able to say good capnograph tracing. So that's just an important thing about positioning. Another thing with positioning, so I've walked into the operating room. Sometimes they don't tell us as an anesthetist. This is an example of an orthopedic procedure that's about to be done. You leave the room, you come back, you find they've already changed the bed, they've put a new bed in, and the nurses are preparing to bring the patient in. And you've got a bed like this, and the patient's head will be right here, and you're supposed to intubate this patient. Some of these beds are so difficult to put into the head up position. And the other thing, you've got this metal device that's in front of you. So you as an anesthetist is going to be standing here at the head of the bed, and you have to manage the patient who is more distal and to you, and there's this metal bar here between the patient's head and you. So it makes it way more difficult to manage this patient's airway. It becomes even more difficult if you're physically challenged because you tend to have smaller hands than your taller colleagues, and also when you're short, your chest might actually be kind of at the level of this bar. So you need to think to yourself, what can I do to position this patient to make uh, airway manipulation easier? Because in this position, you might have a patient with an easy airway, but because the positioning is difficult, an easy airway can end up becoming a difficult intubation just because of positioning. So I'll just tell you what I do. So whenever I get a patient like this, it's non-negotiable. I'm going to use a video laryngoscope, and I normally use a glide scope because a glide scope allows me to intubate the patient even if they're flat. I don't have to put them head up. So normally, what happens with this type of bed, it's very difficult to get a head up. You can't get head up in this position, and with this type of bed, and with this metal device in front of you, it just complicates things a lot. So I I have them put the patient in flat. I use a glide scope, and it's one and done. It's just first pass success, and the tube just goes in the first time. I do not struggle. So you must always think about those things um, when in terms of positioning, especially with orthopedics. They put patients in weird positions, and that goes also speaks to your ability to make sure that you secure the tube properly. So in this some of these procedures, you find they'll put the patient in the lateral position. Some orthopedic procedures will put the patient in the prone position. So you must make sure that your tube is well secured so that it does not come out during the procedure. Drugs is also an important thing that the Difficult Airway Society touches on, and the emphasis is getting the dose right. So if you don't get the dose right, you're not going to be able to get the optimal conditions for intubation. They also talk about the choice of muscle relaxant, succinylcholine versus rocuronium. You have to use your own discretion. However, there is a move away from succinylcholine They do mention the fact that succinylcholine does provide superior intubation conditions, and most of you can vouch for that. But succinylcholine works very quickly. The patients are well relaxed, and that does go a long way to making intubation easy when a patient is well relaxed. However, succinylcholine does come with its disadvantages. The fact that it can trigger malignant hypothermia, and it has a 250 times chance of triggering malignant hypothermia than using volatiles. The other downside of succinylcholine, unlike volatiles, is that if you trigger malignant hypothermia in a patient, taking away this, you can't take away the succinylcholine once you've injected into the patient. Whereas if you've given volatile, you can stop the volatile and the effects of the volatile anesthetic in causing or exacerbating the malignant hypothermia crisis can actually be reduced. But once you give sux, you can't. So you're going to get, once you give succinylcholine and the patient has a risk of malignant hypothermia, they are going to get a full-blown malignant hypothermia event. As to opposed, as I said, as opposed to volatiles, if you stop them early, you can actually prevent the patient from getting a full-blown episode. So rocuronium is more attractive because it has a less, it does not cause malignant hypothermia. There have been instances of anaphylaxis following rocuronium administration, but they are few. Okay, so there are few instances where rocuronium has been implicated in anaphylaxis, but those incidents are few. So if you want to get optimal intubation conditions in a patient whom you intend on performing a rapid sequence induction, your rocuronium must be, you must use a very high dose of rocuronium. You're looking at about 1.2 milligrams per kg of rocuronium that you have to give to a patient in order to get them adequately relaxed in 90 minutes. Succinylcholine at a dose of 3 milligrams per kg, you will get optimal muscle relaxation within 45 to 60 seconds. But rocuronium, you need double the amount of time. You need about 90 seconds in order to facilitate that. Rocuronium can be reversed using sugammadex, which is a cyclodextran, which chelates the drug and takes it out of the system. At a dose of 16 milligrams per kg, you can completely reverse the rocuronium dose, regardless of how much you've given the patient. And the patient will be breathing normally within 3 to 5 minutes, as if they actually never had any muscle relaxation. Succinylcholine has no reversal agent. Remember, it's broken down by butyrylcholinesterase in the body. And if your butyrylcholinesterase is not functioning properly, or if you have a deficiency, you end up having a condition that's called succinylcholine apnea or scoline apnea. And those patients will need to be ventilated for a prolonged period of time, and the treatment is you are going to take the patient to the ICU, continue ventilating them, and you're going to give them a fresh frozen plasma in order to break down the succinylcholine. So patients who are at a high risk of having prolonged muscle relaxation after being given succinylcholine are patients who have malfunctioning butyrylcholinesterase, a deficiency in butyrylcholinesterase, and these deficiencies occur in patients with liver disease. Pregnant patients also have been noted to have a prolonged neuromuscular blockade following administration of succinylcholine. Then dosing. So propofol, you must give the adequate dose for you to be able to induce the patient. And then while you're performing laryngoscopy, remember propofol does not last long, only about 3 minutes. So from the time that you give the propofol to the time that you intubate the patient, if it's more than 3 minutes, there is a very high risk that the patient is going to be aware at the time that you perform laryngoscopy. So it's necessary to give a top-up dose. However, giving a top-up dose does increase the risk of hemodynamic instability, more especially in the elderly patients who develop hypotension about 8 minutes following the administration of propofol. So the hypotension will not occur immediately after administration of propofol. It typically occurs at about 8 minutes, about 5 to 8 minutes following the administration of propofol. And what happens is that their blood pressures can drop precipitously, and they will actually need to have some vasopressor. They'll need vasopressor in order to rescue them. So what some people do is they will give a little bit of phenylephrine prophylactically for the elderly patients, maybe 50 mics, before they actually give the propofol as a way to prevent that from happening. So administration route, normally we give these drugs IV, so that's an important thing to note. During the time that you're managing the patient's airway, it's not just about making sure the patient is well oxygenated, but laryngoscopy itself does alter the patient's hemodynamics. So patients can, their blood pressures can swing. You know from experience that you can get the intubation response leading to a tachycardia and hypertension due to the stimulation of the nucleus tractus solitarius, which leads to vagal stimulation, which leads to a tachycardia and hypertension. So there are ways to mitigate that. And one of the ways you probably know is giving opioids or running a concomitant remifentanil infusion during the time of airway manipulation. It tends to work very well in reducing the intubation response. Equipment, extremely important if you want first pass success without complications. So you must have your whole batch of equipment. And as I've also noted with learners, is uh, they have an idea of the equipment that's required when they're about to manage the airway, but they don't have a method of remembering that equipment. So I don't know about you, maybe you also don't have. So you need to come up with a mnemonic. You don't have to use mine or the one that we use in our institution. You can come up with yours. But over the years, this is the mnemonic that I was taught while training, and I found that it's quite a robust mnemonic. It works. So even if I'm called to the emergency department, which is an unfamiliar environment for me as an anesthetist, because my familiar environment is working in the operating room or theater. So the emergency department is unfamiliar because I don't always work there, and also the people that might be working there may not be well trained in airway management, so they may not be prepared to manage airways. So when I get there, I've got this mnemonic in my head of the things that need to be there before I actually manage the patient's airway. So this mnemonic is helpful. Even if I go to the radiology suite, even if I go to the ward for a resuscitation, when I've got this mnemonic in my head, I know all the equipment I need to have. And I can easily identify what I need the nurse or whoever is helping me to bring. So the mnemonic is IMAL list. You might have your own. So I is intubating stylet, a mask, McGill's forceps, airway, oropharyngeal, nasopharyngeal airway, an ambu bag, and the ambu bag must be checked and found to actually be working. Sometimes you find these ambu bags are not working properly. The bag part might be damaged, so it might not be inflating as well, or the valve might be sticking and valve might not be working. So you need to make sure that the ambu bag is actually working and has been tested. Laryngoscope, also the same thing. You might find, especially in the ward, because they don't perform many laryngoscopies, you might find the batteries are flat. So when you try and switch on the laryngoscope, it's actually not working because the batteries are not they're flat. So you must make sure that the batteries are actually working. Endotracheal tube, you want one size above and one size below. Suction, make sure your suction is connected to the wall and is working. Have a syringe because that's what you're going to use to inflate the cuff of the tube. And a cuff manometer is also helpful so that you can actually check that you have not excessively inflated the endotracheal tube cuff. And tape to make sure that you can secure the endotracheal tube so that it doesn't come out. So that's your mnemonic that you can use. If you don't have one, adopt mine. It will help you. Then video laryngoscopes is an important thing that they emphasize in the current difficult airway society guidelines. They are even talking about making the video laryngoscope your first option for laryngoscopy. So I worked in a hospital where video laryngoscopy was our first option. So if you reach for a direct laryngoscope, the consultant was uncomfortable with that. And even the nurses were uncomfortable with you using a direct laryngoscope simply because they did not want any airway incidents. So they wanted trainees to use a video laryngoscope. Firstly, it increases your chance of first pass success. Secondly, it allows everybody who's in the room to actually verify that you have indeed intubated the patient successfully. Especially when the nurses have to write reports, they're able to write that they witnessed that the tube was sitting in the right space because everybody um, can see it when you are actually intubating the patient. So that's the advantage of video laryngoscopy. However, with making video laryngoscopy, the first line, there are there were fears that were raised by certain groups of people, especially in the UK, that if we make video laryngoscopy our first line, are we going to cause trainees to de-skill in direct laryngoscopy? So there was this article, if you want to read it, if you've got time, you can read it, but it's definitely not a must for the exams. But if you want to read it, uh, it's worth reading. I read this article because I was interested. And the argument is that no. So making video laryngoscopy the first line does not necessarily mean you will de-skill, okay, in direct laryngoscopy if you're a trainee, especially if you're using something like a CMAC, because though it might you use it as a video laryngoscope, you can also use a CMAC as a direct laryngoscope. Okay, so the glide scope, not quite. So glide scope you can't, because when you use a glide scope, you can't use it as a direct laryngoscope because the camera is sitting right at the end, and the technique of using a glide scope is not the same as a direct laryngoscopy. So if you only learn how to intubate patients using a glide scope, that skill does not translate into direct laryngoscopy, unfortunately. And also, equally, if you know how to perform direct laryngoscopy, that skill does not translate to the ability to use a glide scope. So, um, yeah, they all have their own nuances. It's so using a glide scope as a video laryngoscope has its own form of training. You might be able to get away with easy airways with the glide scope, but when the airways become a little bit complicated, it does require a certain level of skill. You actually need to know how to use it properly in order to succeed. So those are some of the issues. But what I would say is you do need training in using a direct laryngoscope. You must not throw away that skill because sometimes you can get a situation that your video laryngoscope is actually faulty or it's not working. So if you've only been trained to use a video laryngoscope, you may struggle to use a direct. So you need to learn how to use both. However, in my practice at the moment, I'm 80 to 90% of the time, I just use a video laryngoscope. Reason why I do that, I want first pass success. Secondly, it reduces the chances of airway trauma. Because what I find sometimes, especially with trainees when they're performing direct laryngoscopy and they cannot see the glottic opening properly, they end up fulcruming on the teeth and they can also cut the patient's lip because the patient's lip can get caught on the laryngoscope blade and sometimes they can cause trauma. And we often note that at the time of extubation, you will see blood on the tip of the tube. You might also see blood when you're suctioning because when they were struggling to perform laryngoscopy, they injured the patient's airway. So that's why I tend to use video laryngoscopy because it avoids the chances of damaging the patient's teeth, damaging the mucosa, uh, uh, and cutting the patient's lip. You avoid all those complications. And also, you avoid drama. you avoid hypoxia, desaturations during the time of laryngoscopy, which you do not want. So that's why I tend to fall back on, I'm more inclined to using a video laryngoscope. However, you need to do what you feel more comfortable with, but the Difficult Airway Society emphasizes the use of video laryngoscopy as first line. So that's what their guidelines are saying now. And it's also institution based. So if your institution does not have video laryngoscopes, then you can't adopt that. You actually need to speak to your procurement manager to get to order a video laryngoscope for you. So that's an important thing to note. Our culture, I must say, when we were training, was to go for the direct laryngoscope. If you are struggling, then we ask for the video laryngoscope. But the current culture is such that you're no longer going for the video laryngoscope because you're struggling, but your first line is the video laryngoscope because you want first pass success. Okay. So your video laryngoscope is no longer a rescue device, it's your main device. That's the new culture of training. But as I said, it depends. If you don't have one, you need to procure it. If you only have one in your hospital and you're sharing it amongst 4 or 8 theaters, then it becomes a problem. You can't use the video laryngoscope as often as you need to because it's shared amongst the different theaters. Then it becomes a bit of a challenge in your setup. So that's an important thing to know. I've talked about teams. So this is an example of a team. You are managing the airway, but you're not alone. You've got a team. You've got someone who can bag for you. You've got someone who can help you hold the mask. You've got someone who can help you with the video laryngoscope or fiber optic scope. What we have found is that when you work with an airway team, the chances of having airway catastrophes are way less. So this airway team was working during the time of COVID. And managing the patient's airways, managing the patient's airway. Um, it's just because it's not just about COVID, but you still can have airway teams even in the operating room, and they also reduce the chances of you having problems. So in our hospital, when you've got issues, you call for help, and calling for help does not mean you are incompetent. In fact, it shows that you are mature, so you should never be afraid to call for help. I still call for help. I'll call for someone to help me hold the mask. I'll call for someone to bring me a video laryngoscope or another blade or to apply cricoid pressure or something. I always am open to call for help. And the nice thing in our hospital, it's a non-judgmental environment. If you need help, people will help you because at the end of the day, we all are focused on the patient's care. We want to have good outcomes. We're not here to show off our skills or show off to one another. Our focus is making sure we have good outcomes. So if you ask the nurse, help me with this, the nurse will help you. If you ask someone to help you with intubation, they'll come and help you. So that's how it should be. So the Difficult Airway Society algorithms are still quite similar to what was in 2005. However, in 2025, they have implemented this algorithm. So this is the first algorithm they talk about. Then this algorithm comes from examining the patient. And what they have done in these present guidelines is to call forth for awake tracheal intubation from the outset. So is awake tracheal intubation not something that is going to be an afterthought. They actually advocate for it the moment you get in contact with the patient. They say that, do you think that this patient is going to be difficult? If the answer is yes, if you think that this airway is going to be difficult, consider awake tracheal intubation. I know you guys are DI anesthetists. You may not be trained in awake tracheal intubation, but if you feel that patient needs awake tracheal intubation, then you should actually get someone who is a specialist or to handle that patient. This is not the patient that you should be anesthetizing. And this is what they're advocating with our current guidelines, is to think about awake tracheal intubation early on. You won't be able to make this decision unless you've assessed the airway. So again, you must take a history. You must examine the patient, re-stratify the patient for possible pulmonary aspiration, physiological difficulty, and also imaging. Like I showed you the picture where the child had a grossly enlarged tongue that you could see was actually obstructing the airway. That type of patient, you can't give your propofol and expect that you are going and paralyze and expect that you're going to be able to intubate. You're going to have serious problems with that patient. That is definitely a patient for who needs an airway team, will need ENT, will need consultant anesthetist to manage that patient, because that patient is going to be difficult. And this is what they're talking about, thinking about awake tracheal intubation early. So if you feel that, yes, patient might be difficult, but awake tracheal intubation is not required, then you're going to proceed with an intubation, but asleep. And this is where now we branch off into the other algorithms. So I won't go into awake tracheal intubation. If you want to read about it, you can take a picture of this QR code and go to the awake tracheal intubation guidelines. But for the DA, they will not examine you on the awake tracheal intubation. That is for specialist level. So specialists will be asked about awake tracheal intubation and how to perform it. But for the DA anesthetist, they don't expect you to know that. So we will take this arm, and these are the algorithms I'm going to show you. So there's plan A, B, C, and D. Those who've read the guidelines before, they've maintained them as is. They start off with the master algorithm of the unanticipated difficult tracheal intubation. So, plan A is actual tracheal intubation. Plan B, supraglottic airway device. Plan C, mask ventilate. Plan D is the emergency front of neck airway. What they've changed with the guidelines is that they call for front of neck airway early. In the previous guidelines, front of neck access or front of neck airway was lower down. Now they are talking about ensuring that the emergency front of neck access kit is accessible from the beginning. So if you're struggling to intubate, your front of neck access kit must be available already, though you may not use it. You will proceed to insert a supraglottic airway device if you're struggling with intubation. But at the same time, now at this stage, you're opening the front of neck access kit. Then by C, you try and mask ventilate. At this stage, the emergency front of neck airway kit is opened, and whoever's going to do it is ready to go. So the emphasis now is thinking about plan D much earlier from the beginning, and it must not be something that's an afterthought. Okay, so that's the difference with the current guidelines. And also calling for help early. So planning for plan D early, calling for help early, and also throughout this process, oxygenating the patient. So you're going to pre-oxygenate, and while you are performing your laryngoscopy, you keep oxygenating the patient. You can do that, as I mentioned in previous tutorials, by having nasal prongs in the patient's nostrils and running that oxygen while you are performing laryngoscopy. It's possible, and it won't hinder your ability to intubate the patient at all, but it will create a safety net to prevent the patient desaturating and having a hypoxic arrest because of lack of oxygen. Okay, so if you succeed, then you will continue with the procedure. You intubate the patient, you continue the procedure, you confirm that the tube is in. And what they talk about is 2-point check. So the 2-point check is one, you saw the tube go into the glottic opening. Number two, you were able to see the capnography waveform. And after 6 waveforms, you know that this tube is adequately placed. It's not actually sitting in the esophagus. So that's what you would do. So failure to intubate, you then consider Should I wake this patient up? Should we potentially postpone this procedure to another time? And there are consultants who've done that. So don't be afraid to make that decision. If you feel you can't intubate this patient, rather wake up the patient. Wake up, try and consider waking up the patient. And if you can't get help, reverse and wake up the patient. So if you've given rocuronium, you can easily give Sugamadex and attempt to mask ventilate the patient and wake them up. If you feel that help is coming, what the guidelines advise is not to reverse the patient, but rather to actually make sure the patient is well relaxed so that you can be able to mask ventilate them with ease. And also, if you're going to get someone to do front of neck airway, the patient needs to be adequately relaxed for that. So you need to make that decision. So that's why on the right side you're seeing wake up the patient, uh, uh, or you might just proceed without intubating, put a supraglottic airway device, or you might then consider front of neck airway, like a tracheostomy or crocothyroidotomy. But it's case by case. No one can tell you do this. It's something that you would need to decide on as to what is the most safe thing to do. Um, Most of the time, waking up the patient might probably be the safest thing for you to do, and get senior help or consider doing the procedure on another day. So we've had those instances where we were struggling, airway became bloody. It's an elective procedure, it's not an emergency procedure. Suction, wake up the patient, and then do the case on another day. Plan A. So far, the Difficult Airway Society guidelines, and they even state that the focus has been on tracheal intubation. However, sometimes when patients come to theater or the operating room, your aim might not be to intubate the patient. Your aim might just be to insert a supraglottic airway. So that's one thing that they mentioned that they kind of neglected in the guidelines, because there are some patients that you plan to put in an LMA and not actually intubate. So what they mentioned is that if your first plan is a supraglottic airway device, you need to consider the similar issues as well. So sometimes the supraglottic airway device does not sit properly, or you're struggling to get it to ventilate the patient. Then what you need to do then is to intubate the patient. So if you're failing with the supraglottic airway device, you can't get air into the patient, you can't ventilate the patient, you have to intubate the patient. If intubation is difficult, after you've attempted the supraglottic airway device, then you're going to must ventilate the patient. And then this is the stage where now you need to decide: do I wake up this patient, or do I keep the patient paralyzed and we're going to do front of neck access? Yes or no? Those are some of the things you have to decide on. So, but the guidelines, uh, the assumption is plan A is intubation. I'm just stating that so that you know, because your plan A might not be, but in this case, the default mode has been to intubate the patient. And what they state is, with your plan A, you must make sure you've checked all your equipment, you've already examined the patient, you are ready to go. You have maximum three attempts. So with each attempt, you need to think to yourself, what am I doing wrong, and what should I change? So if you try to intubate the first time, you need to ask yourself, what is wrong? Am I having difficulty placing the tube? What can I do? Maybe if I ask the nurse to release cricoid, it can help me. Or if I get laryngeal manipulation, that might help me. So with each and every attempt, you have to change something. You can't have a fixation error where you keep doing the same thing over and over. So repeated attempts lead to airway trauma. And by the time you get an expert to come and help you, the airway might be traumatized, the airway might be edematous, and therefore it will make it extremely difficult for the person who's coming to rescue the patient or the person who's coming to help you. So it's important for you to think about that. Again, as I mentioned, video laryngoscopy is something that they're emphasizing. Adequate neuromuscular blockade. Make sure the patient is well relaxed. Because if the patient is not well relaxed, it's going to make intubation difficult. Okay. Have situational awareness. Know what's happening. Don't just keep trying to intubate the patient and the sats are going down to like 70 or 50. You need to stop. If the sats are going down rapidly, stop. Must ventilate the patient. Get the sats up first before you try again. Okay, so that's an important thing to note. And once you have managed to intubate, remember the 2-point check, which is you confirmed that the tube went into the vocal cords because you saw it. Number two, you confirm with waveform capnography. If that fails, then you're going to move to supraglottic airway device. What they emphasize is using a second generation. So if you struggle to intubate and you need to put in a supraglottic airway device, you shouldn't be using a classic LMA. Okay, you should be using a second generation LMA. So a second generation LMA allows you to suction through it so that you can suction gastric contents, because at this stage the risk of aspiration is high because you've had 3 attempts already. You struggle to intubate the patient. Obviously, you might be bagging in between, so the chance of aspiration is high. So you need to use a second generation supraglottic airway device, and you need to suction the patient's stomach to reduce the chances of aspiration. Another important thing is you must make sure that you have head up position, because a supraglottic airway device is not a definitive airway. The patient can still aspirate. Okay. So it's important to have that understanding. So I've told you before that I've had 2 instances. One when I was a trainee, and the other one when I was just newly qualified as a specialist. I struggled to intubate an obstetric patient. And what did I do? The first instance, I called my consultant, and while he was en route, because it was at night, he told me that I should proceed with the supraglottic airway device. And I did that. And we managed to do the Caesar. I put the patient in the head up position. And when he came, I asked him, should we intubate the patient? He said no. He said, leave the supraglottic airway device in situ. Let's just be ready to suction the patient, and let's remove the LMA when the patient is fully awake. And that's exactly what we did. That was the first Caesar under general anesthetic I did with the supraglottic airway device, and we didn't have any problem. The patient did not aspirate. So even in the UK, this is one of the things that the Difficult Airway Society has also mentioned, is that you can actually do a Caesar using a supraglottic airway device if you have struggled to intubate. However, you must use a second generation LMA. You must suction also the stomach so that it reduces the chances of aspiration. So it's important to know that, because patient will not die from inability to intubate, but patient can die from hypoxia because you couldn't oxygenate the patient. So in LMA, as long as it's sitting properly, you should be able to oxygenate the patient. You should be able to ventilate, which means you're going to expel CO2. And if you've suctioned the abdomen, head is up, chances of aspiration are minimized. You should be okay. Okay. But there are certain surgeries where an LMA will not be possible. Like, for example, if you struggle to intubate and the surgeons want to do laparoscopic surgery, you shouldn't be using supraglottic airway device. I know if you check on the internet, there are some people who have used supraglottic airway devices for laparoscopic surgery, but I'll say that is not wise, because if you're doing a laparoscopic cholecystectomy, for example, a supraglottic airway device, it's going to be so difficult to ventilate the patients. The airway pressures are going to go high. That patient can become very difficult to ventilate, and also there's a high risk of aspiration. So you need to think about that again. So if you're struggling to intubate, use a supraglottic airway device. Again, the guidelines also say you need to think to yourself, should we still proceed with this surgery? So in my instance, it was an emergency Caesar. We decided to proceed and then exercise caution with the patient. Okay. Sometimes you may, like for example, the instance I gave with the cholecystectomy, and they want to do it laparoscopically, you can't proceed with the surgery because it's going to be high risk. The patient also is going to be in a Trendelenburg position. It's going to be very difficult to ventilate the patient. In that instance, once you've put in the supraglottic airway device, you'd consider waking up the patient and rescheduling them for a different day when there's expert help to manage that patient's airway. Then we move to plan C. So plan C is final attempt. So with plan C, what you're basically doing is you just want to oxygenate the patient, you want to ventilate the patient, get that CO2 out, clear the CO2. You definitely are not going to proceed with the surgery at this stage because you couldn't intubate, you couldn't put in an LMA. Now it's just keeping the patient alive and considering what's the next move. So in that case, um, you then reverse neuromuscular blockade. This is what they say. Get senior input, reverse neuromuscular blockade, and wake up the patient. If you're struggling to still mouth ventilate, that's when you would consider front of neck airway, either a tracheostomy or cricothyroidotomy. Okay. So what you want is you don't want to have a stage where you're going to end up having to put in a cricothyroidotomy. So even in the guidelines, there are not many, that doesn't often happen. Okay. And they even mention in the guidelines that they don't want that to happen to people. To the extent that if people have to, if any anesthetist has to be involved in cricothyroidotomy, they actually advise that after that incident, there has to be some form of counseling because often people get traumatized by that because you would have attempted to try and intubate, failed, tried to put a supraglottic airway, fail, tried to mouth ventilate, you fail, and now you have to do needle cricothyroidotomy. So by the time you have to do that, it's actually it's traumatic. So they they don't want you to end up at that stage. And how do you avoid that from happening from you? So the principle is noli pontes igni consumere, which means don't burn your bridges. And how do you prevent yourself from burning your bridges? Examine the patient. So in the Eastern Cape, so we used to have a lot of patients coming in with Ludwig's angina. And if you know the pathophysiology of Ludwig's angina, and especially in our setting, what would happen is these patients would have tooth decay, and there was poor access to dental care. And what would then happen is they would develop a tooth abscess, it will complicate, and then they would come in with Ludwig's angina. And this is how the patients would present. They've got this gross swelling that involves the submental area, and there'll be a huge pus collection in this region, and sometimes they even have difficulty breathing. So if you induce this patient, you give them propofol, you give them muscle relaxant, this huge abscess can potentially obstruct the airway because what happens is that once you give the propofol and the muscle relaxant, you lose the tone of the airway. The muscles become relaxed, and the mass that's resting, this mass of pus that's resting on the trachea, then collapses the trachea, collapses the airway, and the patient can have difficulty breathing, and they can have either partial airway obstruction or complete airway obstruction. So the principle here is don't burn your bridges. So what would we do with this type of patients? Would have them breathing spontaneously and then would make a decision. Are we going to have an awake tracheostomy in these patients, or are we going to consider an awake tracheal intubation? Again, this is not your case as a DA anesthetist. It would need a specialist to be around to do these cases, but you need to be aware of them. So if someone says to you, just anesthetize and intubate this patient, we're going to be fine, you should say no, because this is the type of patient that you can potentially lose the airway, and then you will end up with Plan D. Okay, so for you to institute Plan D also can be difficult. With the Ludwig's angina, sometimes it's okay. You can actually manage to get an emergency trachea in them, as long as you've got someone who can do it. But when you've got a massive goiter, putting in a tracheostomy, it's like you can't do that, because how you cannot access the trachea at this stage, because you need to go through the goiter, and this goiter might be extremely vascular. So when you try and cut through this goiter, it's going to bleed. Then it will be catastrophic. So this is the typical example also of don't burn your bridges. So if this patient is going to be anesthetized, you have to make sure that she is continues to breathe spontaneously. And if the patient has a retrosternal goiter, you shouldn't be doing this case, because that case requires cardiothoracics, or and you might also need a perfusionist if you've got a retrosternal goiter, because you're going to run into trouble with this particular type of patient. Another patient that might be a problem is a patient with microstomia. So this patient, you can already see you cannot put in the laryngoscope blade into this patient. It's not going to fit. Your only option is either you have to do a fiber optic intubation. Um, you have to decide, are you going to do it awake or asleep in this type of patient? Because it will be definitely, it can potentially be difficult. So you have to go either the nasal route or the oral route. The other thing I want you to also appreciate with this patient is that this patient has got facial muscle atrophy. So mask ventilating this patient is going to be very difficult. So if this patient desaturates, you may not be able to mask ventilate them adequately. Firstly, their mouth is small, and also you may not know if this nasal passage is actually patent as well. Uh, that's another thing that might be difficult to judge just by looking at the patient. So this is a patient definitely you're going to think of having them breathing spontaneously as you manage their airway. If you think about this principle, whenever you're managing the airway, you'll avoid yourself going to that plan D, which is uh, um, putting in a cracothyroidotomy. This is just showing you the overview of the awake trachea intubation. But as I said, for your purposes for the exam, they're not going to ask you this. So this is just for completeness' sake. So with awake tracheal intubation, what we do with these patients, we oxygenate them, we topicalize the airway, we sedate them, but we allow them to continue to breathe. This is so that the patient is comfortable during the procedure, but we do mention to them that they're going to be generally awake, yeah, and they might cough in the process, but it's normal because they're awake. And we're doing it awake because the risk of doing it asleep is much greater than doing it awake. And then after you've oxygenated, topicalized the airway, sedated the patient, you then perform the procedure. And when you do awake tracheal intubation, you always need to have another person, either respiratory therapist, anesthesia assistant, or another anesthetist to help you. So it's not a procedure that you just do on your own. It actually requires a second person who has understanding of managing the airway to be present with you. This is the last one now, Plan D, emergency front of neck airway. So this does come in the exam. They do ask us. I was asked this also in the emergency medicine DPEC exam. They wanted to know, how do you perform this front of neck airway? So you need to know how to do it. Um, you need to have a general idea. So in the subsequent slides, I will show you step by step what the guidelines say, So you have to know it, unfortunately. Some of them are like, oh no, this is too much. But you have to know it for the exam. It's important. So there are about 9 steps. So the first step is you have to identify the laryngeal So there are 2 ways of doing it. You can pre-scan the patient using ultrasound to identify the structures, you mark them off, but you have to be trained in airway ultrasonography, and most people are not. So you just have to use anatomical landmarks. So you just have to feel for the laryngeal anatomy, and you need to put the patient in the neck extension. Once you locate the midline with your, once you locate the midline, you want to then make an incision, a vertical incision in the midline, as they're showing you here. And you start from the bottom to the top with the scalpel in your dominant hand. After that, you make a blunt dissection using your hands. You identify the cricothyroid membrane with the index and non-dominant hand. After you've done that, you make a transverse incision over the cricothyroid membrane, and then you twist the scalpel blade through 90 degrees, and then the blade must then point caudally, which means towards the feet. When you have done that, you hold the scalpel with your non-dominant hand, and you move to step 7. At this stage, you've basically cut through the membrane. So the assumption is now you are basically in the trachea. That's what we are assuming. So that's why you then put in your bougie. So you can slide in your bougie. And then once you've placed the bougie, you hold that bougie now with your non-dominant hand. So you initially use a dominant hand to push the bougie in to the trachea. You now hold it with your non-dominant hand, and you railroad the tube through the bougie. You might even get an assistant to help you railroad the tube through the bougie, and you use a size 6 cuffed endotracheal tube and you inflate it. If this tube is too big, you can use a smaller size, but the guidelines generally say you should use a size 6, and you inflate the cuff, and then you're going to connect it to your ventilator. And if you are in the right place, you should be able to get a capnograph tracing. And that's how you do front of neck airway. So the guidelines are there as well. So if you miss this, you can always Google them. Difficult Airway Society guidelines, emergency front of neck airway, and you will see all these steps. Then rapid sequence induction. So they talked a little bit about that. And I think it's not something that you guys don't know about already. So again, they emphasized the issue of taking a history from the patient, examination, relevant investigations. They emphasized giving antacids. We don't normally do that, or giving prokinetics. So example of a prokinetic is metoclopramide. So metoclopramide, you can give that as well because it helps mobilize abdominal contents. That way it reduces the chances of the patient aspirating. Using an nasogastric tube, if possible. Sometimes it's not always possible. I know with the bowel procedures, if the patients have got bowel obstruction, our surgeons normally put in a nasogastric tube and suction gastric contents out. That reduces the chances also of aspiration. So if you're going to do rapid sequence induction, they do advocate that if it's possible, you have an nasogastric tube and suction it if it's present. And your suction must always be on hand, as I mentioned. Head up position, about greater than or equal to 30 degrees. Pre-oxygenate to greater than or more than 0.9 or 90%. That's your FiO2. And consider high flow. However, high flow oxygen, remember, it's not as good for pre-oxygenating as compared to Thrive. Thrive is more superior than just normal high flow oxygen, because high flow oxygen sometimes is not as your patient might not get up to that 90% because of mixture from the gases in the atmosphere. So I would say if you're going to pre-oxygenate, rather use a mask or Thrive. Rapid onset of anesthesia. So that's why we want drugs that are going to give us a one-arm brain circulation. Those are the drugs we're going to give. For example, propofol, so that our patient can go to sleep quickly. We want to use muscle relaxants that work quickly. So if you've got succinylcholine, we can give it. But remember the complications that come with succinylcholine. If you need to avoid it, then avoid it and give a higher dose of rocuronium. Here, as you can see, 1.2 milligrams per kg of rocuronium is given for the rapid sequence induction, or 1.5 milligrams per kg of succinylcholine is given for the rapid sequence induction. Cricoid force, they still talk about using cricoid force. However, people need to be trained how to apply this cricoid force, because some people think they're doing the cricoid pressure properly, but they're not. So they still advocate for the use of cricoid pressure, though it is controversial, but the guidelines still say use it. Then they talk of gentle mouth ventilation. This is when you have to balance the risk of aspiration compared to hypoxia. So if you have to mouth ventilate the patient, make sure that your pressures are less than 20 centimeters on your APL valve, so that you reduce gastric insufflation, because air takes the path of least resistance. If you have high pressures, you're going to end up pushing air into the abdomen, and then you increase the risk of aspiration. So you don't want that. So, and another thing that you can do, head up position, reduces the chance of aspiration, and then you can gently ventilate the patient. They advocate the use of video laryngoscopy from the outset to increase the chances of first pass success, and the use of bougies or stylets, especially when you're using devices, video laryngoscopes like the GlideScope. It's very difficult to intubate without a stylet. You have to put in a stylet, because directing the tube to the glottic opening is almost near impossible without a stylet or a bougie. So you need those devices, especially with video laryngoscopy. So, in conclusion, the guidelines say that all this information is great, but it's not enough. Knowing all of this stuff is not going to make your anesthetics automatically make your anesthetic safer. There needs to be there needs to be a safety culture in your institution, and there needs to be some form of training. So what you have learned today, if you don't implement it, you don't take necessary measures to incorporate it into your practice and do it often and practice it often, it's not going to help you. It's just going to be information, and it's not going to improve your ability to achieve first pass success and improve patient safety in your setup. So that's why simulations are important. That's why teams are important, who actually understand these guidelines, who have knowledge of these guidelines, or if they don't, you teach them, and avoiding fixation errors. Some, as I mentioned, you are like, no, I can intubate, I can do it, I can do it, I can do it, and you end up having several attempts, and you end up having a bad outcome. So you must learn to quickly pivot. So, and you must think decisively. So if you feel like I'm struggling with this, what can I do to make things better? Oh, I've tried this, it's still not working. Let me call for help. Have a very low threshold for calling for help, so that you avoid airway catastrophes. Situational awareness, I talked about that. So it goes back to the fixation era. So you need to be aware of what's happening around you. So the example I gave is um, continuing to make attempts at intubation when the patient is desaturating rapidly. That's not wise. You should actually step back, stop, mass ventilate the patient, and think, what are we doing wrong? Should we be calling for help at this stage? Okay. Then I mentioned the issue of systemic changes, so that there is a culture of safety. And in the hospital I was practicing in Eastern Cape, what we did was we got into the operating room and took trolleys out, and we had to reorganize our trolleys in the operating room, so that there was so that they looked like this, so that when you open the airway trolley, you know that the first drawer is face masks, the second drawer supraglottic airways. The third door was endotracheal tubes of different sizes. This type of organization is also part of the safety culture, because then when the nurses see this, they're going to adopt the same pattern, and it makes it easier between anesthetists, even if you've never um, maybe practiced in this particular hospital. But when you get into that operating room and things are orderly, things are in order, things are labeled like this, it's easy for you to access the equipment. And if everything is kind of conspicuous, it actually improves safety. It's part of the safety culture. And also the surgeons as well and other people who may not actually be directly involved in anesthesia, if there's a safety culture, they will be able to pick up when things are going wrong, and they will also be able to assist you. So we've had instances where like a surgeon will actually help you to hold the patient's mask, because if there's nobody else, and you need to do something, maybe you need to quickly draw an additional amount of drugs, the surgeon can hold the mask for you. And if there's no safety culture, the surgeon will say, "No, it's not my job." But if there's a safety culture, the surgeon recognizes the fact that um, their efforts will contribute to the safety of the patient, and they will be willing to help. So the safety culture is important, and that's what the guidelines actually emphasize. That it's not just about getting all this information. It's not going to help you unless this information translates to action, unless this information is continuously practiced, and unless the system itself is open to changing to allow for safety. Otherwise, you just have guidelines and no changes in patient outcomes. So that's about it. It's a mouthful, it's a lot, but I felt it was necessary that we look at the guidelines. And it took me a long time to go through these guidelines, but it's worth it because it's all about safety, and it's important to know how people are thinking in terms of airway management in 2025 going forward, 2026 and subsequent years. All right, so if you've got any questions, feel free to share them. We'll have two scenarios, and then that's it basically for the day.